Chair, the live stream has been started.
Thank you. Welcome to this meeting of the Healthcare and Wellbeing Scrutiny Committee being held today, Monday the 28th of July 2025. For those present in the meeting room, if the fire alarm sounds, please leave the building by the nearest exit and make your way to the fire assembly point in the car park. The agenda papers and other relevant information for this meeting are available for public viewing on the Herefordshire Council website. The Council is streaming this meeting live on the Herefordshire Council YouTube channel and is making a recording. Others are permitted to film, photograph and record public meetings, providing that it does not disrupt the business of the meeting. There are no members of the public present. For participants in the room, please raise your hand to indicate that you wish to contribute. When invited to speak, press the button on the right of the microphone unit and speak directly towards the microphone. Please remember to turn the microphone off once you've finished speaking. Please ensure that your mobile phones, laptops and other devices are turned to silent. Have you done that?
Yes, I have, Chair. Yes, Miss.
For participants in attendance remotely, can I request that you... Oh, there's none, so I won't bother to announce that. So we can go on to Agenda 1 on the item, which are apologies for absent.
Apologies for absence have been received from Councillor Mark Dykes, and Councillor Polly Andrews is present as the name substitute for Councillor Mark Dykes.
Thank you. So that deals with item 2. Item 3 is declarations of interest. Do any members wish to declare any interest in the agenda items? No. Item 4 is the minutes from the last meeting. The minutes document of the meeting held on the 19th of May 2025 are included in the agenda, pages 11 to 18. No matters of accuracy have been notified to the monitoring officer. Are you content that I sign the minutes as an accurate record?
Yes.
Thank you. Councillor, thank you very much, Councillor Andrews. Item 5 is questions from members of the public. The committee has not received any questions on this occasion, and likewise item 6 is questions from members of this council, and we have not received any questions on this occasion there. So moving swiftly on, we are going to have item 7 next on the agenda, which is regarding the Integrated Care Board reset. We have those papers on pages 19 to 56. And the purpose of this is to examine proposed changes to the NHS Herefordshire and Worcestershire Integrated Care Board and their implications for the delivery of health and social care services in Herefordshire. I'll also say that as elected representatives of the people of Herefordshire, it's our role on the Healthcare and Wellbeing Scrutiny Committee to review this agenda item. This reset represents a significant moment in how health and care services are planned and delivered across our area. It follows a period of challenge, reflection, and now reorganisation, aiming to strengthen leadership, improve accountability, and ensure better outcomes for our residents. Today's discussion is a vital opportunity for us to scrutinise the rationale, process, and implications of this reset. We'll be looking at how the changes affect service delivery in Herefordshire, how they align with the priorities of our communities, and what governance mechanisms will ensure transparency going forward. I'll now invite Simon Trickett, who's the Chief Executive of the NHS Herefordshire and Worcestershire Integrated Board, to introduce the report and take us through the key elements of the ICB reset. Welcome, Simon. And we also have David Mahaffey with us, and he'll introduce himself when he speaks. Thank you.
Thank you, Chair. And thank you to the officers for pulling the report together. This isn't an NHS report, it's a report your officers have done, and it's very, very good, actually, I must say as well, which makes my job a lot easier. So I'll just start with a bit of introduction, and then I think the value, Chair, will be in the question and answer and the discussion. So by means of introduction, we have a new government that's just celebrated its 12-month anniversary in power. One of the things that it has been doing during the course of that first 12 months is reflecting on how it wants the National Health Service to operate, which, if we're honest, is what a lot of new governments do when they take power. They take a bit of time to reflect, to review, to consider, and then they come up with a medium to long-term plan as to the direction of travel that they would like the health service to go in. I think that's particularly apt in this current era. We lived through a pandemic, didn't we, in just 5 years ago. We dealt with a lot of consequences of the pandemic, both on increased health need in a number of areas, but also a backlog of care that built up because people weren't receiving normal treatment while health services were trying to help people through the pandemic. We're coming out of that period of recovery, and it's really actually quite a good time to set some more forward-thinking future direction, and that's what the government has done. They published a 10-year plan just about 3 weeks ago, and one of the big elements of that 10-year plan, as Councillor Crockett explained, is a reorganisation of how much resource is directed at kind of back office management functions and the geography that those back office management functions therefore operate over. So the two headlines of that being that we found out, it was the middle of March, that they will be looking to make a 50% reduction in the running costs of integrated care boards. So that's right across the country. It was applied differentially. Our reduction in Herefordshire and Worcestershire was actually 43%, but there were areas, Gloucestershire being one, where I think they had a 58% reduction. So the actual level of reduction that was applied to each integrated care board was dependent on how much money you spent to start with. We spent below average, so we had a slightly lower reduction. But by next April, we're going to have to be spending about £12 million less than we did do this year on running costs. So a huge, considerable change in how we operate. That's good news for patients because that money will be reinvested in frontline services and frontline care, which is always a good thing. But clearly it does present challenges for how we're organising those planning and arranging functions that Councillor Crockett described at the start. So fundamentally, integrated care boards, the simplest way of describing it is the government sets an annual budget for the health service. It's about 190 odd billion pounds this year. That 190 billion pounds is split up into allocations for each geography. That allocation for each geography is basically given to the integrated care board along with a mandate of things that the government would like to be purchased with that. The Integrated Care Board takes that money. So in Herefordshire and Worcestershire's case, our budget for this year is just about £2.2 billion. We take that £2 billion and we place contracts with the hospital, with GP practices, with mental health services, with physiotherapists, with various community services. And we try through those contracts to meet health need in the best way that we possibly can. When it comes to looking forward, clearly the 50% reduction is going to cause quite a significant amount of upheaval to how the Integrated Care Board works. We will be having to make somewhere between 150 and 200 people redundant in Herefordshire and Worcestershire. That is a very obvious consequence of spending so much less. We will still retain all of the legal responsibilities. So the Health and Social Care Act in 2022 set out a whole range of statutory responsibilities that integrated care boards will have. Those aren't changing. There may well be some legislation in a year or two that tidies up some of the detail, but fundamentally the job for the Integrated Care Board will be very similar to the job we've had over the last few years. Therefore, we have had to look at, well, how would we go about undertaking that job with such a reduction in resource, in management capacity. And clearly one of the most obvious solutions is we will need to share resources with a neighbouring or bordering health system, another integrated care board. It's also apparent that there's probably a longer term direction of travel for services like this, but also that's very relevant for local authorities. It seems clear to me that reading the government's white papers on devolution, that remains a big policy imperative. I think they would like to get to a point where local government strategic mayoral authorities that Herefordshire Council will be working on over the next year or two, where there is a coterminosity between the mayoral authority, the integrated care board, and I'm sure there will be discussions as to the geography of things like the Police and Crime Commissioner and the police forces. All of that is to come. Clearly, as of today, as of the middle of 2025, Herefordshire and Worcestershire councils are in a similar position in that they understand you have to pursue a strategic mayoral authority, but there aren't any firm proposals yet developed. And in fact, your neighbours across the border in Worcestershire are busy deciding about how they become a unitary council and whether they have one unitary council or two. That's going to form most of 2025, is my understanding. Once that becomes clear, they'll then set about establishing that unitary authority, and then I'm sure the conversations will begin to gather momentum around what the mayoral authority will look like. So from an NHS change point of view, we don't have the ability in Herefordshire and Worcestershire to match neatly to a mayoral authority because we're probably a couple of years away from that being known. But we have got to get the 50% of cost out. We have got to get the £12 million of cost out. So our proposal, the proposal we submitted to NHS England and to the Department of Health and Social Care, was that we will cluster our teams with those in Coventry and Warwickshire Integrated Care Board. We will keep the two integrated care boards as statutory bodies, but instead of having two teams running those two organisations, we'll have one team whose job will be to provide the expertise that delivers both of the legal responsibilities across that wider area. Clearly, in order to do that, we're going to stretch people a bit thinner. We're going to do things more strategically. We are very definitely, and this is another theme of the 10-year plan, organisations like Wye Valley Trust that run all of the hospital and community services in a place like Herefordshire, they'll step up and provide some of that more local capacity, whilst the commissioning, the Integrated Care Board, becomes slightly more strategic. So we submitted that proposal to cluster with Coventry and Warwickshire. We submitted a plan as to how we would deliver that cost saving, therefore, across that geography. That plan's now been approved, and we're now starting to think about the arrangements that we will need to put in place over the coming months to deliver that much reduced spend by the end of March next year. So I'm very happy to take any questions, Chair, on the ICB reset and the changes. I've asked David to accompany me because quite rightly in your report, your office has described the NHS 10-year plan. They describe the shifts from analogue to digital, from treatment to prevention, and from hospital to community that the government are asking us to focus on. And there's a lot in there to unpick, actually. So there's a lot of conversations. David is our Executive Director of Strategy and Partnerships. David's quite well placed to talk through how we would see some of that strategy manifesting itself in the local health system for Herefordshire patients. So if that's okay as an introduction, happy to stop there and to get into the questions.
Thank you, Simon. It was a very concise introduction. So, this government now has landed us with a whole huge agenda, haven't they? Devolution, boundary changes, and now the ICB reset. It's not for the faint-hearted, and you're going to have to go through an awful lot of hoops and hurdles. You did mention in your introduction about cost cutting, and it's a significant amount of money, obviously, and about voluntary redundancies that would need to happen to meet this. So at present, have you got any idea about voluntary redundancy. And I also note in your report that you were offering the MERS, which is the joint support for that redundancy programme.
Yeah, it's a good question. I mean, obviously, my aim will be to absolutely minimise compulsory redundancies, because we that's not a good outcome for anybody really. We've had now since March to work on this. We've got another 7 months of the year left. There's a lot of time to pass to work with people to try and help them find alternatives. So the 150 to 200 is the headline. I would anticipate, we haven't been filling vacancies since March, so there is a proportion of that can be met from a natural turnover. As the report mentions, we have run an expression of interest in voluntary redundancy scheme, and it's an expression of interest because as of today the Treasury have yet to agree the funding envelope to fund any redundancy. That will clearly be something that we'll have to follow later in the year. As of today, I think about 40 people locally have expressed interest in voluntary redundancy. There will be other opportunities between now and the end of March for our teams to have those types of conversations. We will run the change process in line with people's employment terms and conditions. Everybody in the NHS has, in essence, a consistent contract nationally, so there's a very strict and very clearly defined set of rules as to how you manage these kinds of change processes. We'll be making sure we comply with all of that, and we'll be making sure we do the very best for local people to help them either secure a role in the new clustered arrangement or to secure some kind of alternative role. We're working with the council, both councils across the patch, all the trusts, that any vacancies that become available, that we have a conversation about any integrated care board staff who may be suitable for those. I think there probably are 4 or 5 people we've already been able to redeploy through that. So we'll do our very best to look after people the best we can, albeit, as you say, the context is very challenging. And
my big fear really is that you lose a lot of very experienced staff. We've done a voluntary redundancy program in the council, and we've lost a huge amount of knowledge and experience. So it's not always the best way to do things by going for mutually agreed retirement scheme, and that does concern me.
I mean, in considering applications, we obviously have to consider how we might replace that experience and expertise. The only thing I would say is different this time, that if you've got 2 teams working across Coventry and Warwickshire, Herefordshire and Worcestershire, we might be able to let one person that's got really good experience in one area go, as long as we have another person in the other team who could fill that gap. So it's a complicated equation, but you're absolutely right, Councillor Crockett. The last thing we'll be doing is getting rid of experience that we just can't replace, because that wouldn't be a good outcome.
And as you mentioned, you know, that is the ideal scenario if you've got somebody in the same position, a strong person in either authority, ICB, that you lose both of them, and that's not the best outcome. We've got questions already, so sorry, I don't know whether it's Councillor Andrews and then Councillor Thomas.
Thank you, Chair. Mr Trickett, you did mention very briefly that you'd submitted a plan. Could you share the details of that plan with us?
I don't think it's been made public, but I don't see any reason why it couldn't be. There is an element of it which we had to forecast how many people we would lose per function to redundancy. We deliberately haven't shared that because it's a forecast and an estimate, and I wouldn't want the people involved in delivering that to be unduly concerned. We're trying to manage that, and it's fairly fluid. But the narrative element of the plan we'd be very happy to share with the committee.
You mentioned redundancies. Are we talking about clinical or clerical?
All clerical, managerial, no clinical staff.
All, sorry?
No frontline clinical staff. These are all people that work in planning and organising back office functions.
Okay.
Thank you. Councillor Tillett.
So, given these changes, how will these changes look to the ordinary user of the service, to the ordinary person in the street?
If I'm honest, Councillor Tillett, I don't think they'll notice a huge amount of difference. They shouldn't do. This is about back office organising. The aim will be that we use this opportunity to streamline, to remove duplication, to try and empower more local ownership. And actually, the other thing for the man in the street is, when we deliver this, there is in theory £12 million more to spend on buying healthcare services for them than was available this year.
I think for the layperson, Simon, when Herefordshire join up with any other county or authority, the people of Herefordshire start to worry. They think we're going to get lost in the system. You know, we are the smallest of this cluster that we're joining. So we've got Herefordshire, Worcestershire, Coventry and Warwick. So, you know, how do the proposed changes align with the ICB's blueprint requirements on board composition and balanced representation? Because I know at the moment we have Paul Walker, who's our Chief Executive on the ICB for Herefordshire and Worcestershire. And looking at the combined cluster, we, as Herefordshire, would appear to be the smallest, as I've just said. And it's basically like a coalition. So how can we be assured that we are not going to get lost?
It's a really good question. And I remember coming to a scrutiny committee session probably in about 2017 in the old town hall in the city. And I was asked a very similar question, because at that point I was working in Worcestershire and we were expanding our geography to cover Herefordshire and Worcestershire, and there was a lot of concern in Herefordshire about representation and having a loud enough voice and reflecting difference, because this is a different county to Worcestershire. I know that all too well, having done this job for the last 8 years. We haven't agreed the actual board composition. We're not yet at that stage. The chair isn't appointed. I'm certain we will want strong local authority partner representation. What I would say, for the benefit of the committee, Paul Walker probably has been the ICB's most active partner member, and that's across local government, but also across the NHS and general practice sectors. Paul's been really, really good. He's very interested. I'm sure if Paul wanted to retain a strong involvement, there will be that opportunity. I would just finish by saying as well, my observation is Herefordshire's made more progress with its health service offer over this last 7 or 8 years than it did in the previous 7 or 8 years. The hospital has been quite stable. We have issues, don't we, with waiting times and A&E and urgent care and GP practice waits. But all of those issues in Herefordshire, relative to other areas, we do very well here, and that wasn't the case probably in the decade preceding 2017. So I think the Herefordshire and Worcestershire dynamic has worked really well in this instance for Herefordshire, is my independent and neutral perspective. Our challenge is going to be to make this new, even wider geography work in a similar fashion. I know very well from the work we do with Councillor Gandy on Health and Wellbeing Board, the work I do with Paul, the work we do here with this scrutiny committee, I know very well the moment Herefordshire feels it's not being listened to, it's very good and very articulate about stating that case. So I want to work with you to make sure that we manage any risk around that over the coming months.
Yeah, and I thank you for acknowledging that collaborative approach that we have. I think we as an authority do have a voice strongly represented by our Chief Executive, and obviously we have our Director and Councillor Gandy, who also really help push everything that we're concerned about to the fore. Councillor Andrews.
Thank you again, Chairman. On a more practical level, I understand that the reset is going to emphasise more in community-based care. Well, we're a rural county. I'm sorry, I'm stating the obvious here, am I not? But how is that envisaged? I noticed you mentioned community neighbourhood hubs. How is that going to work in this rural county? Are you putting a neighbourhood hub in every market town? And because it will still mean people, even if you put them into market towns, it will still mean it's not really neighbourhood for people who've got to drive 10 or 12 miles to get to them.
Yeah, I'll pick up that one initially. For rural areas, it's obviously a different challenge to inner London, city areas. I mean, there's a statistic that we quote when we talk about the rurality of our system, that you could get all 5 integrated care systems in London into our geography 2.5 times, but we've only got 10% of their population. And that makes people sit back in central policy teams and go, wow, okay, one size doesn't fit all, does it, when we're talking about these things? And that's going to be our challenge locally, to take that national policy of neighbourhood health and what it means, very different in the London Borough of Camden to the rural places in Herefordshire. And it's a lovely place. I find it a very interesting place to visit, but it's very different, isn't it? And our job locally will be to translate that national policy into something that's meaningful and workable locally. So yes, we will not be able to have a neighbourhood health centre in every village, but what we will try to do is do something that works for the population of Herefordshire by working very closely with public health teams to help us plan out those services, with the council's social care teams, children's teams, etc., to work through the options and come up with something that works as best as possible with the resources that we've got.
If I could just continue. Also, you changed from analog to digital. Well, given the NHS's past experience with its IT systems, good luck with that one. But again, in this county, parts of this our older population don't have access to smartphones, etc. And in parts of this county, accessibility for IT is dodgy, to put it politely. How are you going to address that?
Yeah, you're absolutely right. I mean, you see from my job title, the middle part of my job title is health inequalities, and one of the biggest health inequalities we have is digital inclusion or digital exclusion. So it's clearly something that's front and centre of the work we need to do. We, as an NHS, can't resolve the broadband coverage or the mobile phone coverage, but we can certainly advocate for the need for it, but working with council partners to make sure that we can close issues like that is important. But where people can't access healthcare through digital means, there will always be another more appropriate mean to them, whether that's outreach services that we provide through mobile vans, whether that's face-to-face opportunities in community centres, GP practices, the local hospitals, etc. There will always be an alternative to the digital offer. What we would like to do, though, is where the digital offer is accessible and convenient, to make it much easier for people to access, particularly through the NHS app. That's a big push to get as much through the NHS app as possible, but never forget digital exclusion will leave people out if we don't pick up those through other means.
Thank you. Councillor Davis.
Thank you, Chair. I'd just like to explore the amalgamation of the 2 integrated care boards, Hereford, Worcestershire and Warwickshire and Coventry. When they come together, is that going to mean a complete new hierarchy put into place, or are you going to integrate the hierarchy currently in place with the 2 individual care boards as a starting point?
Yeah, there is already now a process where, in essence, the 2 people in the current hierarchies, to use your terminology, are in a competitive process to determine. So it won't be a third set of people, it will be a selection of hopefully the very best people from those 2 structures to create one team that obviously is hopefully the most capable to do the job in hand.
Is that going to mean that the individual who is successful, or the individuals who are successful to take over the control, will then get an elevated pay packet, bearing in mind they're going to be covering a far bigger area with much more diverse problems?
I haven't seen any details of that. The way the pay currently works, all of the jobs are paid on a pay scale, and it determines, I think there are 4 bands, and the bands relate to the population that you cover. The higher populations, there is a higher level of pay, but there's been I haven't seen any discussion or confirmation as to how that will be applied here, because clearly you're keeping the two integrated care boards separately. So it isn't two jobs, it'll be some kind of compromise that reflects that. But I can't honestly tell you for certain, because that hasn't been confirmed.
But one would assume that there is going to be a significant saving there if two become one. We hope, yeah. Just going back to the governance and accountability side of things, I think really, what are the implications for oversight mechanisms, and will there be changes to the ICB constitution?
I mean, I would see oversight and scrutiny arrangements being exactly the same, albeit the team have had to service 2 local authority sets of scrutiny arrangements. The team is going to be servicing 4 sets of local authority scrutiny arrangements moving forward. The ICB constitution, it won't change to start off with, because the ICB constitution is determined by the Health and Care Act. It's statute. There has been discussion that has revolved around some changes to constitution around how the NHS trusts are represented on the board, and whether that will be necessary going forward. But to be honest, that isn't going to happen until the government bring forward new legislation, and you guys will know better than I, that doesn't happen quickly. That will be 12, 18, 24 months away, I suspect. So until that legislation proposal comes forward, I'm not sure what the detail will be. It might be something, Councillor Crockett, that we come back to at a future scrutiny session.
Yeah, there's an awful lot of we don't know, isn't there? Which we all accept. I know. I was just looking at the Fit for the Future 10-year health plan for England, and the headlines are those 3 main topics. You know, hospital to community, analog to digital, and sickness to prevention. And oh my goodness, how many times can we go round this one, round and round again? And here we are with 3 major system shifts, which aren't, because they've always been there. They're just being brought around. And it would be interesting for Zoe, if you want to come in and say anything on that. But, you know, the frustration to me as an ex-clinical practitioner is, not again, here we are again. You know, why are we trying to change something that has been working? And if it hasn't been working, yes, we need to change it. But, you know, these constant merry-go-rounds of systems that are cyclical just really drives me up the wall. But I need to get off that merry-go-round, I think. And then I was looking at the Building Sustainable Future programme and those 5 core areas. So you've got, you know, frailty, elective care, releasing time to care, prioritisation, and population health management. Again, they're not new ideas. They're just things that have been brought back to the fore, or brought back into the agenda setting for the public. And I'm not sure whether the public are really bothered about those things, because what they need to know is that if they need something, there's already been a process put in to say that will be there, and that's been done from the structure that you're resetting at the moment. So it's trying to make sure that we're supporting everything that you are doing and also needs to be done. Councillor Tillett. I've got more to say, but we'll let him go.
I didn't know who Simon
was. I going to breathe?
Well, no, you didn't give him a chance to respond.
Well, as often in these situations, you're never quite sure whether people are making statements or asking questions, and that might have been a combination of the two. The point I wanted to make, though, was the Building a Sustainable Future. It probably would be unfair to ask me to comment on the 10-year plan, and is it not just the same thing over and over again? That I've seen a number of these longer-term plans, as you would have done as well. The Building a Sustainable Future, though, is under our local direction. So within the buzzwords contained in those 5 areas, we could describe a whole very detailed programme of work that is taking place. So in elective care, primarily our focus is on trying to get the two hospitals to work closer together, and where there are really long waiting times for a service in Worcester and lower waiting times for a service in Hereford, that we try and share that benefit for patients and vice versa. So the Building a Sustainable Future is different because that's our invention. We're running and managing that locally, and that is very definitely targeted at trying to make the health and care offer in these counties we work in more sustainable, so more affordable, more within its budgets, better performing, and we can control that because we're setting that agenda ourselves. It's obviously harder for some of the national things. We respond to national policy and plans, but Building a Sustainable Future is our invention that we're pursuing locally.
David.
I was just add a few comments on the 10-year plan. I mean, as a director of strategy, you do take a deep breath every couple of years when a new 10-year plan comes out. And like Simon, I've been through a few of these iterations now, but actually reading some of the detail on it, there is some genuinely new stuff. And taking a completely apolitical view on this, some of the stuff they talk about around making the NHS app much more population friendly, so much more like your banking app or something like that, which is easy to use rather than complex. The tobacco and vapes bill that's been introduced, that's a really significant move that will see the eradication of legal sales of tobacco to anybody who's turning 16 this year. There's some stuff on obesity, which really is quite transformational. The stuff around neighbourhood health is moving the agenda on, and Simon and I were talking this morning about some of the things that we've done a few years ago are now materialising in other areas, and they're presenting themselves as a new neighbourhood health strategy. But we are moving along that journey towards having a much more local health service, moving services out of hospital, putting them closer into people's communities. I mean, people receive a lot more treatment at home now than they did 10 years ago. 10 years ago, being in a hospital, now you can get that treatment at home in what we call a virtual ward, connected up to the technology to monitor vital signs and etc. So a lot more of that. So yes, it's a continuation of some things that have been going on for some time, but I think there genuinely is some interesting stuff that if we can follow through on it as a country in 10 years' time, the NHS will look a very different entity to what it does now.
And again, just going back to, I think it was the one before last ICB, I think Dr. Fraser gave a prime example of supporting in the community rather than in the hospital. He gave a scenario where somebody possibly should have been in hospital for treatment, but then the community managed it. But those incidents or cases are all very well, but in the long term, how are we going to manage it all? We'll go to Zoe, Public Health Director.
Thank you. So just following on from that in terms of your point around prevention. So obviously I would really welcome that it's one of the 3 shifts is the shift to prevention. And I totally agree. We've heard this time and time again. I do think this feels and looks different, I would say, in terms of what's set out in the 10-year plan around using population health management. So really understanding our data. If we were going back 5 or 10 years ago, we weren't in the same position where we could really look at the data, drill down into it, and really understand the different groups of people that we're talking about, and then put in that prevention side of it, which overlaps really nicely with the neighbourhood health. So that's less about neighbourhood health centres and more about how we understand our population at that local level, really understand our population in Herefordshire and the differences in that population, and then try to intervene before it goes to the hospital admission side, or people who have had one admission to hospital, and look at how do we prevent that from escalating to the 4, 5, 6, 7 admissions, etc. So I welcome it. I think it's a positive. Making it come a reality is the challenge, admittedly.
And again, I really welcome your positivity because this is what we need to have. We've got to look to the future and make sure that we're getting the best out of it. So we'll hold you to account on that one. You've said it on the screen, so we'll watch this space. Councillor Tillett.
Oh, yes. There we are.
Sorry.
That's all right. That's all right. I've sort of got two big biggish bites I'd like to have a go at. One is revisiting something we've already talked about, and something that's...
Oh, is this the elephant in the room?
No,
that's
well,
right
I don't
then.
know. I don't know which elephant's in your room, but you know, we've talked a lot about recurring themes, and one of the recurring themes, certainly in my 6 years on this council, has been the constant battle between the council and the NHS about MIUs. There's a little bit of movement in the Ross direction, I understand, which is welcome, but the argument has always been the lack of staff and the lack of logistics to enable just MIUs in Leominster and Ross to reopen. So I think a lot of people will then go, how are we suddenly going to have all these neighbourhood hubs in every market town, I think you said, David, that are suddenly going to be equipped and staffed when up until even very recently, just reopening a couple of MIUs was out of the question?
I'll start and you can maybe add something. Look, it's a good question. I've been briefed in advance that this might be part of the conversation. That's fine. I came to see Councillor Gandhi and Cabinet members a few weeks ago about this same topic, and we spent a lot of time talking about minor injuries units there as well. So there is no doubt in my mind, of the council's position, of local members' position, that they're looking to restore access to these services. So those two minor injuries units were closed several years ago, as you know. They were closed temporarily for safety reasons, really, because the trust that runs them, Wye Valley Trust, said, look, we can't safely staff these and safely staff the A&E. We've got to prioritise something. So they were temporarily closed, and that remains the position. We, from an integrated care board point of view, we haven't changed the funding. The funding still sits with Wye Valley. I would like the minor injuries units to reopen, albeit I do fully understand the pressures that the hospital are under. We would have been working with them, I'm sure, over coming months to try some other routes to re-establish those. The point was made to me very clearly at the Cabinet briefing that you have minor injuries units in Worcestershire and they're still open. Why haven't they closed?
And you give them more money.
Very good. And in fact, the one in Bromsgrove has had
1.6 million.
some capital investment that Councillor Gandhi is very well cited on. So, I mean, it's a different county, it's a different system. They're run by a different trust, but a very good point that why would the residents in one part of the Integrated Care Board have access to such a service, and then residents in another part of the Integrated Care Board don't get the same access? It's a fair challenge. All I would say is I'm looking to be constructive and to be positive. The focus on neighbourhood health should allow for some different conversations. I mean, in my very simple mind, the limitation of minor injuries units always was really in the title. They were okay for minor injuries. If you sprained your wrist, if you had a bit of a cut, there would be a well-qualified nurse that could tend to that. If you had any kind of medical need, there were no doctors at minor injuries units, never have been and never would be. So therefore, the range of help they actually can offer to residents is really, really very limited. And actually, that was reflected in the very small numbers of people that use them. What I would like to see as we finalise the neighbourhood health development plan is I would like us working with GP practices, primary care networks where GP practices work together, and I'd like that neighbourhood health focus to also have a minor injuries and illness element. So this is the things that you wake up one morning, you don't feel very well, you need a GP appointment that day. I think we should be able to offer through a neighbourhood health service access for that kind of on the day urgent primary care. That will be the aim. I think if we get that right, I think minor injuries units will more formally become a footnote in history because we'll have moved on, and these services will be able to offer help and support both for minor injuries but also for an expanded set of illness on the basis that they will be covered by a doctor. So that's our aim. That's where we would like to get to. We've obviously got a lot of work to do with Wye Valley Trust, with Taurus, with the primary care network, the GPs, and with local authority, because some of these neighbourhood health hub developments will require estate solutions, won't they? I think we've made reasonable progress with GP estates in Herefordshire over the last 7 or 8 years. We have Hereford Medical Group down the road. We have the big development in Kington. We have a new development in Leominster, which is rising from the ground now. Those are all big developments that will really help with neighbourhood health hubs. There are parts of Herefordshire that don't have those estate solutions. So I think there's a joint conversation with local authority about how we progress that as well. David, anything I've missed?
Sorry, can I just? I just want to pick up specifically on that point. So if I'm understanding you correctly, let us take Ross as an example. The development of a neighbourhood hub in Ross would not be what would seem to many of us the logical thing, an expansion of the services at the MIU, but would be completely separate from.
We'll have to look at that in each area. The community hospitals are a really good example. There is an existing building, there is existing estate. Plan A will always be, okay, how could we use that existing estate to try and meet these new requirements? I'm certain there will be instances, and to be honest, before the development, Leominster would have been a good one, where if you look at the general practice estate as has been and currently, it was nowhere near suitable for 21st century healthcare. So I think we're going to have to be quite flexible. But no, we aren't going to develop these neighbourhood health hubs in splendid isolation. We start with what we've got already in each neighbourhood and work backwards from there.
And before we go to Councillor Tully and Andrews, I think Councillor Gandy would like to say something, but
I said I had 2 subjects to talk about.
oh, I'm sorry. And you can,
And besides, David's going to come
you
back.
can come back in a second as well. Sorry. And just thinking about, what you've just said going on in Leominster, we all know, if anybody has been to Leominster in the last decade, that Ryland Street and Westfield Walk surgeries were the most horrendous buildings and estates that we've ever owned. So that's a very good move. Now, I think David wants to come in before you, Carol, Councillor Gandy.
I was just going to add the point about scale, which is a real challenge. So to run an MIU, you need a staff member who's called an emergency nurse practitioner, which is not just a normal nurse, but a highly qualified nurse. They're not that common. So if we wanted to put an ENP into a minor injury unit, the place they would come from would be the A&E department. They're not out there just waiting to be recruited. And the challenge then becomes, Ross, Leominster would see 10, 12 patients a day. So you'd have a full-time EMP seeing 10 to 12 patients a day. In Bromsgrove, for example, it's about 70, 80, sometimes 100 patients a day go through that MIU. So you can justify the need for an EMP in that instance. The only other place in our patch where it's different is in Tenbury. But in that case, the EMP works on the ward. So they just happen to be qualified, but works mainly on a ward. So they're overqualified for ward work. If a patient comes into MIU, they then go down and see the patient in MIU and then go back to the ward. That's the only possible solution, but that is fortunate because there is an EMP who works in Tenbury Hospital who can cover that. But other than that, the challenge of scale is a real issue. And it comes down to, priorities, as you say, safety, value for money, and good use of limited resources that we can access.
Councillor Gandy.
Yes, mine's also to do with levels of scale. We're talking about these neighbourhood health hubs, which are, when I've read the document, going to contain mental health services, pharmaceutical services, physio, all sorts of services. But my understanding is that it is envisaged that they will cater for between 30 and 50,000 population. Now, that would mean for Herefordshire, there would be 4 for the whole of the county. So that is actually probably less than we've got now. So, and if you think about where you would put 4, one would obviously possibly be where you've already got one in the city, and then you've got 3 to spread around the rest of Herefordshire. So actually, we would probably be well, I would be worse off. Well, I'd carry on going to Ludlow, but or Tenbury, but actually, we because of the nature of our population, because this document has been written specifically based on urban areas by people who live in London, Manchester, whatever, and not in Herefordshire or Northumberland or somewhere like that. This is not a 10-year plan for the rural areas of our country. This is a 10-year plan for the urban areas of our country. And let's be clear about this. If you think you are going to get a better service from buildings closer to where you live than now, then you are absolutely wrong. If this follows through in the way that it does, and I think if we as a council do nothing else, we should make it clear that we do not accept the idea of having these hubs covering a population of between 30 and 50,000 people in very rural areas.
So that might be a question that we, this scrutiny committee, can suggest to the executive. Absolutely. Yeah. Sorry, Councillor Tully, we've kept you waiting so long. I hope you haven't forgotten what. No. Thank you.
I wrote it down, so it's okay. And I'm sorry, Councillor Tillett, that I've gone in front of you. A lot happened in the last 2 minutes, though, in my brain as well. So it is interesting, I think, what I've just heard, what you said, Councillor Gandhi, about numbers of people and space. And, you said, David, about the numbers that you can see each day and how that is a lesser number. Yes, it's a lesser number because there are fewer people in that area and the area still needs accessible care. So I think that it's really interesting. When you look at the numbers, yeah, it doesn't add up. Herefordshire doesn't add up. Shall we close it? I just think that's a really interesting point. And you said about the ENP and an ENP and an MIU, and there aren't that many of them. And Tenbury works because they just move from one part of the place to the other. So it's just occurred to me that would make the case for there to be an MIU in every community hospital. Because that's, if you've got, okay, so then let's put an MIU everywhere there's a ward. Because if there's somebody that can work in a ward, then, and I didn't preface this with, I'm very new on this scrutiny board and this is probably all nonsense. So that's just my thoughts. The question was, you mentioned sustainable futures. Was that the phrase, Simon, about you were talking about the two hospitals. It sounded really positive, absolutely great, and much less logistically possible over a wider area. So I wonder whether you have any concerns yourself about some of the good work that's been going on and some of that communication that's been going on between Herefordshire and Worcestershire, and how you're going to keep what you've achieved as a sort of two-county project.
Really good question, Councillor Tully. If you're new to it, you've picked up the key points very well. No. It's a good question. Look, you learn very quickly in a job like this. The worst thing you can do is to force people to be the same, and I'm sure it actually applies at council level. That the worst thing the council can do is to assume Hereford and Ross-on-Wye and Leominster and Ledbury are all the same place. You have to embrace the difference, because the difference actually is probably the strength of the county, and I would certainly apply that from a health service perspective. I've learned the hard way sometimes, really. You cannot force people to do exactly the same thing. Our strength in Herefordshire and Worcestershire is the sense of local identity. That's very strong in Herefordshire. If I'm honest, Worcestershire isn't really a place. It's a collection of communities similar to Herefordshire. There is a badge and a map. There's a line on the map, but most of those communities wouldn't associate with each other. They would see themselves as being very different. So that approach leads you to a particular perspective you have to take on strategy. And the strategy is, you've got to drive value from encouraging sharing, but that isn't the end game in itself. The end game is better results for patients. And sometimes you can get better results from patients from people sharing resources. Sometimes the best way of getting results for patients in our system is you actually empower that local community, those local services, to say, look, I hear that you're different. Well, what's the answer? How is this different in Ledbury? And tell me, walk me through how that can best be achieved. And you have to be quite adaptable, I think, from a management point of view, an administrative point of view. You have to embrace that difference. So the specifics of the two hospitals, what we can't do is instantly expect a whole shared service model and for all the patients in Herefordshire to travel to Worcestershire, for all the patients in Worcestershire to travel to Herefordshire. That just won't work. The geography absolutely constrains that. If we're honest, in lots of instances, we can't expect staff to work 2 days a week in Hereford, 1 day a week in Redditch, 2 days a week in Worcester. The travel time would pretty much take up half of the working week. So we have to be pragmatic about it. But there are a number of pretty fragile clinical services. You will understand, because it's exactly the same for lots of local government services. You're looking for particular expertise that's probably in short supply nationally. How do you convince them to come and live and work in a place like Hereford? It's really hard, isn't it? It must be really hard to recruit experienced social workers or experienced planners. It's very hard to get that level of expertise. You have to therefore make some compromises, and you say, okay, well, we'll accept some flexible working, or can we have a local team, but can you provide the supervision? Can you use your expertise to provide some supervision and oversight? Can you be the place to go to if somebody's got something that's just too complicated for the local team to deal with? So it's those kinds of links and sharing and supporting which will form a much greater part of what we're trying to describe than any moving people around and changing services. It's about bits of the National Health Service. Let's be honest, we are a National Health Service. The bits in Hereford and the bits in Worcester agreeing to back each other up and support each other, specifically in those services where there's a fragility. And there are just as many fragilities in Worcestershire as there are in Herefordshire. I mean, great example, Worcestershire have a really fragile dermatology service offer, skin. Herefordshire's dermatology service is really good, so they're providing that support. Herefordshire struggled with haematology. There's an ongoing conversation about stroke where Worcester is quite a bit stronger than Hereford. And we're not saying, right, well, all those haematologists, you need to go and work in Hereford now. But what we are saying is that team in Hereford that's a bit fragile, can you hold their hand and be at the end of the phone, and can you support them? And can you provide maybe some on-call cover? Those kind of things are all very doable if you get the culture right, the mindset right, and the context that you're asking people to work in. And that's really where our elective care work in particular is focused. And just to finish on your first point, wouldn't it be great if the funding formulae, both for NHS services and for local government services, reflected the additional costs of delivering services to a rural population? That's our biggest challenge, and it's a collective challenge, actually. I've worked in local government for half of my career, in the NHS for the other half of my career. We get a really poor deal in both senses for funding formulae. We should continue our joint efforts to try and get the formula to reflect the actual costs of doing what we need to do.
Thank you, Simon. Councillor Andrews, did you want to come back?
Yes. Could you tell me, in this new scheme of things, and some of which I've heard before, like Councillor Crockett, I worked for the NHS for many years, and I'm seeing things come round in circles, which they always do. But where are the GP practices are going to feature in this new scheme? And could I also comment, when I first came to Herefordshire, we lived in Ross, and it was Pendine practice at the time, used to supply medical support to the service, the cottage hospital. Yes, yes. I realise that GPs today seem to have rather more limited scope, or choose to have more limited scope, but you seem to be suggesting we go back, the wheel is full turning.
I'll start, and then maybe David might want to add something. So the question of what role will GP practice play, I think, is a really important one. The strongest part of our health system in both of the counties I currently work is our GP practice offer. I know it doesn't always feel like that. I know there are frustrations all the time with people struggling to get access, but actually, relatively speaking, our GP practice performance, it's the best in the country. It is literally number one out of the 42 integrated care systems in the country. So where you have an element of strength, and when you are considering new strategy and approaches, it's a fairly logical starting point that you start with what's working well. So I will be looking for local GP practices, for Taurus, which is the collective body in Herefordshire that pulls them all together, to play as much of a leading role in that as they are willing to take on. Clearly there's some conversations, it's got to work for them in terms of resourcing, but I would want our neighbourhood health models to be very clearly led by GP practices and primary care networks. David, anything you want to add?
I don't think so. I mean, back to Councillor Gandhi's point, the 30 to 50,000 is largely based on PCN footprint, so primary care networks. So in Herefordshire, we've got 19 primary care practices that are organised in 5 primary care networks that are kind of in that scale. Clearly, they all cover huge geographies. You know, Northwest Herefordshire is a big geography, isn't it? So those primary care networks, or whatever they become called in the new approach, will still be a key feature of practices working together to provide resilience to each other. But I don't fundamentally see us going from, you know, way less than 19 GP practices, because the model of general practice is based on individual practices serving particular populations. So it's absolutely at the bedrock, the foundations of the new neighbourhood health model. But what it will be called in a few years' time may well be slightly different.
Thank you. Before I come to you, Zoe, you mentioned about the GP survey, and I find some of these surveys really flawed, to be honest. The national survey was from December 24 to April 25, and as you said, we went from 4th to 1st, but there were only 152 responses. So I think that small amount of voices doesn't really, to me, doesn't stack up, and that goes alongside the MIU data. We do not know definitively all of that data, how many people are coming in for, you know, a bad hand or whatever, or how many people need to actually go to A&E. And until we get that data, and I don't know whether this would be a recommendation or a question that we can ask Cabinet to continue with, we need to get the data to be able to give us an informed debate. Zoe, you wanted to add something?
Yeah, thank you, Chair. So in terms of neighbourhood health, we've talked quite a lot about the hubs and our buildings and our focus on people going into walk-in centres. But I think the exciting bit in an area like Herefordshire is actually the neighbourhood health in its widest sense in terms of talking about different ways of working. So the guidance talks lots about multidisciplinary teams, which at the centre of it are your GP practices. There's already conversations going on with primary care networks about what that might look like. So admittedly, that's with particular focused groups of patients, so you're talking 2 to 4% of the population, but high service users, ones that actually end up in hospital through frailty or cardiovascular, and how do we shift that to more prevention and look at a whole multidisciplinary team around those patients to stop the 6, 7, 8, 9, 10 admissions, etc., and catch it at the very early stages. And I think the exciting bit for us there is that actually we've got that work at community level through Talk Community that's really strong. So for me, it's the how do we connect that up of what's already in place at a community level. How do we connect that with the clinical side, which will be the multidisciplinary team, which is aside from having an actual physical building, but more about a different way of working. So we've looked at the Northamptonshire model recently and how that's worked with actually one key person going into the person's home taking that initial assessment, talking to them about what matters to them, and then pulling in lots of different professionals to get that real wraparound support for that person and to stop those repeated hospital admissions. Now, to me, that feels really sensible for an area like Herefordshire, and actually takes us away from talking about those physical buildings and more about who are our high need population and how do we stop those repeat admissions and do what's right for the person at the heart of it.
Yeah, absolutely. Again, you mentioned place-based working, and I'm just thinking now about Health Watch and those possible changes with the Health Watch system, or whether it even disbands, because Health Watch in Herefordshire is a thriving listening ear and local voice, and I think they bring a huge strength to our services. So what's the impact on relationships with local councils, Health Watch, voluntary sector partners and provider collaboratives?
Yeah, I mean, I find the Health Watch proposed changes a bit sad, to be honest, because I would agree with you. The current structures we have in both the counties are stronger than any we've ever had around patient representation. Christine Price and team here, Simon Adams and team in Worcestershire, they actually are a really important part of our health and care system. The proposals currently are that health watches will be abolished, I think in 2027. It came out when I was on holiday, I haven't quite caught up on the detail, but and their responsibilities will pass to integrated care boards in some form. I think we need to see the detail of that, and I will need to reassure myself that we've got appropriate considerations in place to do a good job of that. I think it would be an obvious thing maybe to feature on a work plan for the committee as to how, when more detail is known, how that's going to play through, and how will we make sure we don't lose the voice of residents and patients in some of these debates? Because Health Watch has been very, very good at making sure that voice was properly articulated.
When I first came to
Councillor Gandy, do you want to say something?
Yeah, sorry. When I first came to Redditch in 1979, I became a member of what was then the Community Health Council, which is the beginnings of the same thing, really, made up of people who were members of the public, which is what I was, with other people who were more specialist, and we had the opportunity to go around to hospitals and GP surgeries and things like that. But we were able to take in the complaints that people have about perhaps the services that they receive. And although within hospitals we have PALs, I think, having worked in a hospital for many years, I think sometimes people are nervous about going to PALs because they see it as part of the hospital, whereas Health Watch is being seen as something completely independent. So I'm really concerned that there's going to be a massive gap here about how members of the public actually who have concerns about a service actually find somewhere to go.
And I think, interestingly, there was an open letter sent to the Secretary of State from all Health Watch chairs, well, 131, I think it was, to find out what is really going to happen. And I think, you know, at that point, once they get the reply to that open letter, I think all local authorities should be supporting, or if they don't think it's the right decision, not supporting. But I think we in Herefordshire need to step up and support that Health Watch service that we've had. Any other comments at this point before I go on to something else? Is that okay? One of the things I was looking at on the BSF, the Building Sustainable Future programme, was about the Work Well programme. And this is, excuse me, a supported service funded by the Department of Work and Pensions, I understand, but it will be delivered locally. So do you have a definitive budget for that, or is it just in that very conceptual stage? Here we go, David, thank you.
No, it's a real service. It's really live at the moment. It's run by Taurus. They employ 3 work and health coaches who are available to support anybody who can either self-refer, be referred by their GP or referred by their employer in to have the support they need to help them stay in work if they are struggling with a health condition, or get into work if they are currently out of work because of a health condition. The vast majority of cases that the work and health coaches see, sort of 40 to 50%, are mental health, stroke, anxiety related conditions, followed by musculoskeletal, back pain, neck pain, etc. But the coaches are there to work with the individuals to either navigate the work system, if it's applying for jobs, supporting them with CV writing, applying for jobs. If they're in work, then it can be speaking to their employer about reasonable adjustments to their work, or if they are actively working but struggling, it can be signposting them to the right service, such as talking therapies or various voluntary sector organisations. But it's live, it's there now, and I would encourage anybody who's out of work or in work but struggling with a health condition to go and see a work and health coach, and they can apply, that's not quite the right word, they can be referred by their doctor, or they can self-refer through the website and we can provide details.
So a follow on from that then, so is it well attended? Is it, you've got 3, are they full-time coaches? And, what is the success? Is it, I suppose it's not been measured yet because it's still sort of relatively new.
Yeah, they're the 3 coaches. I think they are about 2.4 whole-time equivalents. So I think 1 is full-time and 2 are part-time. But it's only been up and running for a few months, so it's the early days. We would like to see more people come through the process. It's picking up. I think there are about 40 in the pathway at the moment. The feedback we've had from people who've used the service has been excellent, but we just need more people to be going through the service. The coaches have capacity to see more people than are being referred to them at the moment. So
the way to access that is through the GP, or can you self-refer?
You can self-refer.
So again, now my question is, how do our communities know that this is going on and you can self-refer to that service? Because until I read this BSF, I did not know about it. And I'm in the business.
We are doing a marketing campaign, for want of a better phrase, to make it known for people. It's in job centres, it's advertised in all of the GP practices. There's quite a lot of work on social media. You will see adverts on the back of buses and in bus stops and things like that, strategically located. But it is a case at the moment of just building awareness to it. As I say, the coaches can see more people than they are seeing at the moment. So we are in that process of building awareness. It's early days. It's funded for 3 years. Recently announced that it will be extended for another 2 years from the original pilot that we started in about 9 months ago. But raise awareness for us, please. Anything is greatly accepted.
So my bat it back to you now is, can you not contact the parish councils either through Talk Community, through the council? We've got a 70-something Talk Community hubs. So promote it through Talk Community hubs and also the parish councils. And if you get it to parish councils, you'll get it across the county.
Yep, absolutely. That's a good suggestion. I don't know whether they've taken it to parish councils, but it's run, as I say, by Taurus, who runs the Talk Wellbeing service, which is closely aligned to the Talk Community service. So it's just a case of getting that awareness out there, but I'll certainly take that back and make sure that it is.
And a lot of Talk Community hubs do have contacts in the parish councils, but, some of those that don't, then we don't want to miss anybody out.
Yep.
Simon, you want to?
Yeah, just a quick one, because it reminded me. One of the things the Secretary of State said when launching the NHS 10-year plan, which I think is really relevant, that the health service has to see itself as a contributor to economic growth. So Workwell is a great example of what can the health service do to help people get back into work so that they can contribute to wider society. So seeing ourselves as a facilitating and enabling service rather than just a service that, to be blunt, benefits from economic growth because it means we get more funding, playing more of a part. And actually, I think Workwell's a great example, but we should be probably directing more of our energy to more things that enable people to live healthier lives and contribute more to society. That's something I'm sure we'd all agree with. but it's a mindset shift. I haven't heard that in the NHS to this point, so it's something we should be trying to focus on, I think.
Thank you. Any other questions? Councillor Tillett.
Right, slight change of focus. Special educational needs and disabilities. It says options to streamline and transfer some activities out of the ICB. So streamline how, transfer which activities, and perhaps most importantly, transfer where to.
Yeah, I had a feeling we might be asked. There are a few bits of detail in common with other conversations we've had that we just don't know. So they talked about safeguarding, they talked about SEND, and they talked about infection prevention control. And the ICB has legal responsibilities where it comes to SEND. We are fortunate stroke unfortunate to work in 2 counties where there are significant challenges with SEND services. So in Worcestershire and in Herefordshire, there are very significant, as you know, children's services improvement programmes, of which appropriately meeting needs for children with special educational needs and disabilities are a key feature. What I've asked the same question as you, and I've been told that there is going to be some further national work to define what is meant by that term. Just for the committee's reassurance, we won't be making any changes anytime soon, because I think the improvement plans in both counties are at such a crucial stage that we can't afford to lose any momentum. So I put a lot of time in, people in my team put a lot of time into supporting Tina Russell here with that journey, and we'll need to continue that. If some legislation appears one day that changes my role, if it asks Wye Valley Trust or the GP practice to play a different role, we'll deal with that transition then. But please take my assurance that we won't be changing anything in the short term, because it's too crucial.
Is that reassurance?
I think as much as we can expect, yes.
Thank you. I've got 2 more things, and then I'll wind it up, I suppose. Councillor Andrews mentioned quite a while ago regarding broadband and accessibility, and I know from your BSF that AI is going to be quite a big project. At the moment, you've got the Ambient Scribe pilot in progress, and this Ambient Scribe is going to be on trial in Herefordshire, I believe, from autumn this year, and that's going to be looking at supporting nurses leading on CHC assessments. CHCs are horrendous. I've tried to deal with some CHCs on a personal level, and no wonder people give up, because if you don't meet criteria A and 1 in A and 2 in B or whatever, it's completely thrown out. So I think that's a really good move forward. I also wonder whether this artificial intelligence is compliant with the ICS Green Plan. We at the council also want to support net zero energy consumption, and we're very green orientated. And to me, one of the comments that you made, Simon, in I think it might have been the ICB meeting of this month sometime, your daughter noted how much energy ChatGPT used, and I know ChatGPT goes around this building. I hear it in corners all over the place, and I'm worried that all of this additional energy we're sucking from, our plan to make everything a bit more sustainable and a bit more green. So your daughter's got something to answer to in this respect as well.
I'll tell her when I get home, because I did say that. You're absolutely right, and I'm pleased you picked that up, because my daughter's 21. That generation are really environmentally aware, and she says to me, we shouldn't be using ChatGPT, Dad. There are huge servers that take a lot of energy to run them and keep them cool. You've got to be really careful that it isn't a net zero implication just deciding to use artificial intelligence. There is an energy demand. We need to be aware of that, don't we? I think we have a responsibility collectively to be aware of that. Having said that, where artificial intelligence makes staff and patients' lives easier. You obviously have to net that off against the energy used, and we've got to try and get that equation right. I think society is going to see a revolution, really, in terms of how some of this technology is used, both across public services, but also actually in commercial services that are offered to us as well. I think the CHC example is a really good test case because, as you say, it's a hugely resource-intensive element. So when I mentioned we've got £12 million to save, that means our total budget is about £25 million. We spend about £10 million of that running continuing healthcare services. So it's nearly half of our spend because of the volume of work that has to go into it. So anything we can do to use technology, and it's kind of ambient scribe, which is basically automated recording of conversations, but it's much cleverer than that. It then organises the information into categories. Continuing healthcare assessments are all really algorithm based. Have they got this? Yes. Have they got that? No. And you're working your way through a decision tree. And critically for patients, there will be the ability in this pilot for patients and families and carers to log into a portal to see where their assessment is in the process. And again, I think that's massive, and I reflect on the energy we could save by avoiding people having to ring up, to write letters, to come to meetings, to ask those questions that actually, if we get this right, will be at their fingertips if they're not digitally excluded.
And I think that's quite right, that access is available for patients to see what's going on. Not only saves on time for the person who's having to keep repeating it and asking somebody else, but so that they've got an up-to-date idea of where they are in the system or process. Okay, my final comment really is about the budget setting and resource allocation mechanisms across Herefordshire and Worcestershire. Will they be effective? Because I've been looking at the annual plan and the accounts for last year, and Herefordshire has welcomed several significant business cases, and I've got them here as the examples. So significant businesses that we had developed in Herefordshire are the theatre developments, which is supporting elective services to get those waiting lists down. We've also got the Community Diagnostic Centre in construction, and that will be, I think, pivotal for the community idea of, if you've been seen by somebody, they say you need an x-ray, go down to the diagnostic centre, get that x-ray done. You don't have to come to Wye Valley to get in that system, so I think that's a real bonus. You've also helped in the mental health dormitories eradication programme, and the ICB have had the funding resource for the Leinster primary care premises development. So whilst those are all welcome, looking at the business plan for 25-26, the system suggests that it will continue to explore opportunities for further capital bids that enhance clinical and operational delivery, subject to the availability of the associated revenue funding. And we all know in any business, you've got to get the money, you've got to get the business plan to get the money to back it up. The business cases that are in the process of being developed for 25-26, and this is according to your annual report that was published 3 weeks ago or something, including the accounts, which were pretty impressive, I thought, really show that Worcester will be getting the majority of those big businesses in the next 12 months. So I don't want to end on a negative, because we have succeeded so much, but I think as a whole concept, we as a committee have to acknowledge that there are concerns about this reset, and there are also opportunities. So can I just sum things up? Is that okay? Mm-hmm. Yeah. So one of the key concerns is the risk of being overlooked. So Herefordshire, as we've all mentioned, it's a rural county with different needs for the more urban centres in the cluster. Councillor Gandy mentioned that as well. There are concerns that its health priorities such as GP shortages, rural transport and access to local care could receive less attention in a larger system. So that's a concern. Secondly, with strategic decisions made at cluster level, often led from Coventry or larger hubs, local communities may be less influenced over what services are available and how resources are used. And finally, on a key concern is some services could be centralised or relocated, requiring patients in Herefordshire to travel further away to a different hospital or a specialist care unit. And again, Simon, I think you've mentioned that in your in the report, that we can't all have the specialities of everything because it's not viable. So opportunities, I think. The cluster could provide access to a wider network of specialists and services for complex health needs. We could gain benefit from recruitment and retraining across a wider area, helping to tackle local shortages and for doctors and nurses, and get them to realise what Herefordshire is about. You know, we are, I say it because I'm Herefordhian, we are an amazing county. And a larger system may bring more investment, especially in digital tools, prevention and better use of data to target inequalities. So I've tried to balance it. You know, there's pros and cons to it all. Any comments from any other committee member? Councillor Tillett.
Just a really overarching question. In terms of the 10-year plan, you know, what do you see as your priorities? And what do you need? What are the obstacles? What are the things in the way?
Yeah, I mean, as we've mentioned, there are large elements of that 10-year plan that are a bit mothered in apple pie, and they are things that we've been trying to achieve and we will continue to try and achieve. For me, the big change this time is the neighbourhood health emphasis. I think there is a huge opportunity to turbocharge that. I think we have a strong basis in Herefordshire. I think we have reasonable GP practices, primary care networks. We have decent community services. We do have really good relationships. I think the strength in the team in Herefordshire. So that opportunity to turbocharge the neighbourhood health delivery is absolutely the thing I would be focusing on as a priority. I think, what do I need? I think we need ongoing support from the council in particular, from the local authority. It's critical. It's been a big part of the story of, you know, relative success. And I think your list, Councillor Crockett, that you've just described, they're all things that we've been able to develop in the last few years. And if you go back another few years, there are other things that we've been able to improve locally. So the council's ongoing commitment and support to this agenda is critical. Yeah, and I'm very happy that you continue to hold us to account, and where you feel that things aren't working in the way they should be, the Scrutiny Committee is a big part of the voice of the population of Herefordshire, and we fully respect that, and we're very happy to kind of have those conversations with you here, to describe the circumstances behind where we're at, and actually to receive suggestions where people have got better ideas of things you're missing. And what I find members are really good, particularly from a communication and awareness perspective. So Councillor Crockett's point about parish councils, talk communities, that's a really good point. I'm not sure we've picked that up in how we spread the message around work well. So that kind of constructive challenge is really, really important. So, you know, I need you to carry on with that, and I'm sure you will.
Be assured we will.
Yeah, I was just going to ask, perhaps Zoe or Councillor Gandy, you know, having heard Simon's priority, and to a certain extent, even what he wants of us, how well positioned are we to provide that?
I couldn't agree more in terms of the neighbourhood health focus. Yeah. For me, when I read the 10-year plan, or 160 whatever pages of it, that the neighbourhood health runs throughout all of that. Now, I reiterate my point around we can think about neighbourhood health in terms of physical centres, but we can think of it for Herefordshire in terms of the opportunity that that has to link with our real sort of asset-based, really local community strength that we have here. How do we link that up with the clinical provision, and what does that look like? And I think that's got a huge opportunity for us. So we're already having those conversations. I think it is building on those good relationships that we already have here at place level. And therefore, in terms of the ICS and the ICS clusters, that's the big picture. But for us, it's the local picture in terms of that neighbourhood health, and how do we use that in terms of prevention as well. And I'm not talking prevention in terms of 10, 20 years' time. I'm thinking somebody who's had that one hospital admission, somebody who we know has got hypertension, how do we intervene early and stop that from ending up in terms of the 5, 6, 7, 8, 9 admissions to hospital? So I think that's got huge opportunity.
It's funny you mentioned that. I was just thinking, don't use the NHS app, but no, I shouldn't say that. Councillor Gandhi, would you like to add anything?
Yeah, I mean, I absolutely agree with what Zoe has just said. I do think that's where as a council, that's where we have a big part to play. I visited a Crown Bowling Club in Golden Valley yesterday afternoon as part of my cabinet role, where a group of people in a very rural community were playing a game that I have never played in my life before. But my husband and I, we did our bit along with the Talk Community Development Officer, and it was amazing to see the way that mainly older people, but nevertheless, it was an opportunity for them to get out and about and in a really rural community, and we can work with groups like that to sort out some of the issues around their mental health and their physical health. I think the one thing which we haven't actually touched on today with regards to the ICBs and the cluster that worries me a bit is the document talks, and rightly so, that the new clustering of ICBs will need to build up partnership working with people within their areas, and that's absolutely right. And Hereford and Worcestershire's ICB will, to an extent, for at least a year or so, remain the same. But there are some things coming down the track which will probably change it in a different. But the points will go in a different direction. But I think we need to be clear that the relationship with Coventry and Warwick will only be for a short period of time, because ultimately the ICB footprint will be the same footprint as the local authority, devolved local authority footprint. So for our ICB and ICBs and all those ICBs that have not gone through the process yet of devolution, I think this has come too soon for us. I think we should be left as we were, because it means that there's going to be an upheaval again in 2 to 3 years' time for all staff, which is seems to me to be very unfair when we get to a stage where we determine what footprint we're going to be in as a devolved authority, and that hasn't happened. So I see the really good sides of this, but I see from the ICB's point of view that this is quite a difficult thing for them to manage over the next few years. From the point of view of the members of the public, I suspect most of them have never heard of the ICB and probably couldn't care less about the ICB, don't understand it, and even if they're listening in now, they still don't understand it. But but I think for us that are working within that area, we realise the importance of it, and it needs to be well run and be able to operate properly. And I don't think having this sort of mid-point shuffle is a good thing.
And that's why I mentioned it at the very beginning about, you know, have the government got this right to be changing, you know, devolution, ICBs, and also our boundary changes. Councillor Tillett, you've got something to say.
Don't you love a scrutiny meeting which is dynamic and responds to real-time events. But somebody has just sent me a press release that's just been issued. Shropshire Health Rehab and Recovery Units to close as health bosses announce major shift to community-based care. A major shift towards community-based care will see the closure of county hospital rehab and recovery units amongst a range of measures to support patients closer to home. This winter, health leaders across Herefordshire's integrated care system say they're driving... Shropshire's, I beg... What did I say? Herefordshire.
Yes.
Oh, Shropshire.
Yeah.
The scheme is aimed at supporting patients to recover from illness, but will, as part of the move, the rehab and recovery units at both Telford and Shrewsbury Hospital will close. Is this a sign of things to come, I guess, is the question.
I don't know. It's a bit unfair of you to ask me to comment on Shropshire. To be honest, Councillor Tin, I didn't know anything about that.
I know. That's why I'm very grateful to the person who's just sent me the press release.
What I do know is they're going through quite a big reconfiguration of services at Shrewsbury and Telford Hospital. They're actually changing their A&E departments, aren't they, to only have one. They're changing their maternity services. I can only assume those changes are part of that wider change process. I think they've got £350 million of government capital money to facilitate those investments. But look, I'm commenting as an interested bystander rather than somebody that's involved in that. But clearly for us, we have to take great notice of what's happening in our bordering health systems, both in Wales, in Shropshire, and to the south in Gloucestershire. And we'll be in touch with colleagues to try and work through any implications for us.
Fair enough.
Thank you for being hot on the press there.
Well, thank you to my source.
And thank you for Simon for addressing that one, even though if it's a bit of a curveball, but hey ho, that's why we're here. So any other comments from officers or Councillor Gandy? No?
No, I think I've covered everything that I felt was important to say.
Thank you very much.
And I think you've given a very good airing on what I think is a really important subject.
Absolutely. We will definitely be keeping abreast of all this and watch this space. Any other comments or questions from committee members? No, I think we've exhausted everything. I feel exhausted anyway. Okay, so what we have to now consider is the recommendation of this agenda item.
I've not received any recommendations from the committee.
No.
The only recommendation is a watching brief. See what happens next.
Oh yeah, for the...
No need to make a recommendation on that. That's
No.
just committee business.
Yeah. So committee members, the recommendations on this agenda item are as per A, B and C on the agenda. Do you want me to read them out or not? No. So could I have a proposer?
I'm happy to propose them.
Councillor Tillett and a seconder. All those in favour of accepting this? Thank you very much. Okay, unanimous. Thank you very much. Thank you very much for attending. Could I ask that we have a 10-minute adjournment and the meeting recommence at 15:48? Time is started again, please.
Confirm, Chair, the live stream has been restarted.
Thank you. Welcome back to the Health, Care and Wellbeing Scrutiny Committee. We are still Monday the 28th of July 2025. So we're looking now at agenda item 9, which is adult social care demand task and finish group terms of reference. And I'm going to hand over to our scrutiny officer, Daniel Webb.
Thank you very much, Chair. The committee have embraced the recent review of scrutiny and its recommendation that we explore different ways of working going forward. The Chair and the then Deputy Chair of this committee met with Hilary Hall, the Corporate Director for Community Wellbeing, to discuss ideas for task and finish groups. And they agreed quite quickly that one of their priorities was to look at the demand for adult social care, the inexorable increase in the demand for adult social care, and how the local authority can rearrange itself to meet that going forward. What we have then presented to you is terms of reference to agree to set up this task and finish group. This will consist of up to 7 members of the local authority. It doesn't have to be members of this committee. It could be any member of the council who's not sitting on cabinet presently. That group would then form to decide upon the scope of the work. We just have a terms of reference to agree to set up it to determine how the range of policy areas that it would choose to look at, the different partners that it would look at, and the areas of work that it would like to focus on. We would bring that back to the committee at some point for them to agree on, along with a final report having carried out that work. The intention is that this work would form the backbone of this committee's work for the year ahead, and following our work programming meeting this afternoon, our formal schedule of work programmes would fit around this work going forward. So it's really for the committee to decide today whether it wants to carry out this piece of work. If it does, both Henry and I will put into action the work to put the group into place.
Thank you, Daniel. And I think we've had a few meetings regarding this, committee members. So what we're looking at is the appendix to this, which is the terms of reference, and I hope you all are happy with those because we have read them and discussed them in a previous meeting. So what I would ask now is for the committee to agree to form a task and finish group as Daniel set out according to the terms of reference. Can I have I'll propose it. Seconder? Yeah. And all those in favour? Thank you. So we can carry on with that one. Thank you very much.
Thank you, Chair.
Would it be advisable to send an email to all group leaders to ask if they would like to share this opportunity? Yes.
Well,
Thank
I think
you very much.
to all councillors, rather like they have done with the other one.
Yeah, but group leaders would then.
I would like to remind the committee this is a scrutiny is an party political process, so we would send it to all elected members for them to.
I was sorry, I was capturing people by their groups and not by their individuality, which is perhaps wrong of me. So yes, if we could offer it to everybody, so if anybody has any special interest or commitment to these ideas, it would be really worthwhile them joining our merry band. And the other final thing is the chair of that task and finish group does not have to be the chair of this scrutiny. So if anybody would like to take that one on board, they can. If not, I will step in. So we'll go from there. Thank you. Okay, so moving on to item 9 on the agenda, which is the update on recommendations made by this committee. And you've got before you the list of Appendix 1, which is the list of recommendations. And going through them, I'm not going to go through them every line by line, but there are a few that have been accepted and we could perhaps move to remove them from this list if they've been satisfied, and add anything to our work programme that we feel needs further investigation and consideration. So any committee member, does anybody have any comments on anything specific on that recommendation list? I think these have been going on for a little while, so I hope that things would have come up in the past if there was going to be any need for any significant change. Yeah.
All I would say briefly is that, for instance, the recommendations following the CQC inspection of the county hospital, I won't say have been superseded by some of the discussions this afternoon, but certainly, for instance, the whole minor injuries unit ongoing saga is now clearly back in the melting pot, shall we say? So I think we have to sort of kiss goodbye to that line of inquiry, certainly for a while, anyway.
Thank you, Councillor Tillett. And yes, I think we explored that quite well this afternoon, brought it back to the fore, and just to let NHS, Herefordshire and Worcestershire, ICB, aware of our continuing interest in it. So with that, can I ask for a proposer? So we note the responses to recommendations that we've made and decided on any further actions that need responses to its recommendations. So again, I'll propose, seconder, yeah, all in favour? Thank you. Nobody's against or abstaining. So we're going on to the final item, which is item 10, and I think Daniel's already alluded to this item. So we'll just, this is the work programme for 25-26, and I'll ask Daniel just to make some comments on that one as well, please.
Thank you very much, Chair. The committee at the moment doesn't have a work programme going past this meeting, so it has two pieces of work that it needs to conclude urgently. You met earlier this afternoon to discuss items for your formal work programme, and we'll take those forward and share them during August with you for refinement. The other aspect of that is your work programme for your task and finish group. And again, although you have done some work to begin to shape that, your scope's nowhere near ready for that yet. So I would suggest that the people to do that scope now going forward are the people that form the task and finish group. So again, over the course of August, we'll secure that membership with you and work with them to produce that scope. But really, I think for you as a committee, you do need to sort of work quite urgently to pull together a programme from October going forward.
Yeah, thank you, Daniel. And I think we all agree with that from that conversation we had prior to this meeting, to try and catch up on this work programme. So the covering report recommends item A and B, and I have no other comments. Any other comments from committee members? Councillor Andrews.
That is the safeguard and the deprivation of liberties. I think, Councillor Crockett, you were part of the scrutiny when we looked at this before. This legislation is truly eye-watering when you actually go into it. It really is.
Yeah, I think safeguarding and Dole's deprivation of liberties is something that we will be looking at.
It really is, truly. You cannot believe it as you go through it.
Well, you can believe it, but you don't want to, yeah.
It's amazing, isn't it?
Yeah. So again, we will make a note of that one. So can I have a proposer for the work programme? Councillor Cole, thank you. And Councillor Davis, seconded. All those in favour? Yeah, unanimous. Okay, so that's brought it all to an abrupt end, actually. So the date of the next meeting is the 27th of October 2025, and that's at 2 p.m. And I thank you all again for your attendance and input to this meeting. Could I ask that the live stream is stopped?